Okay, thanks everyone. My name's Tina and I'm a fourth year obstetrics and gynecology resident at UBC, and we're going to switch gears to endometrial cancer now. So this talk is about assessing the parameters of race, ethnicity, and geography in endometrial cancer and the impact on treatment and outcomes in BC. I have no disclosures. And again, I just want to acknowledge we're on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Briefly, we're going to go over the background, the objectives, our methods, as well as the results summary and future directions. So a bit of background. Uterine cancer is the fourth most common cancer among females in Canada, and endometrial is the most common type of uterine cancer. It's the second most common cause of death in gynecologic malignancies. In terms of the 5 most common cancers in Canada, uterine cancer is the only one that's projected to both increase in incidence and mortality up until this year and beyond. In BC, this year, there's estimated over 1,000 people will have a new diagnosis of endometrial cancer, and almost 200 people is projected to pass from this disease in 2024. So there's quite a significant burden on a population level and increasing rise in the number of new diagnoses. We'll briefly go over some ethnic and racial disparities. I want to preface by saying that this data is extremely limited and it's a very understudied area in cancer outcomes. This data is not routinely collected at our health jurisdictions and across Canada, so everything I'll be talking about is from the US. It has been widely studied in the US for the last 2 decades, and there are significant disparities in endometrial cancer diagnosis, treatment, and outcomes. In terms of diagnosis disparities in the US, the incidence rates are similar between different racial groups. However, Black and Hispanic women are likely more diagnosed at an advanced stage. And there's differences in the type of endometrial cancer. So Black women have higher rates of more aggressive histotypes, as well as higher rates of P53 mutation, which has less favorable outcomes than other molecular subtypes. And just on the red, on the top chart, is the proportion of Black women with non-endometrioid histotypes, which are more aggressive. And then the proportion of P53 mutated in Black women is 71% compared to the 53% in white women in one study. There's disparities in treatment. So Black and Hispanic populations are less likely to receive definitive surgical treatment, minimally invasive surgery, and inflow sampling for full staging, as well as less likely to receive chemotherapy or guideline-compliant treatment. In the US, disturbingly, there's a 2 times higher rate of death among Black women for uterine cancer, and the 5-year survival is statistically different. And even when we adjust for age, stage, histology, equal access systems like what we have here in Canada, and hysterectomy prevalence, the death rate is still higher. So what about in BC? BC is a heterogeneous population, as we all know, and visible minorities account for over 1/3 of the population, and this was in 2021, so this landscape is still changing. There's little to no data in Canada and BC regarding endometrial cancer prevalence, outcomes disparities in different ethnic or geographical groups. And our population is diversifying, so every minority group is growing in size, and the percentage of visible minorities relative to the proportion of the total population is also growing in size. All this to say is, with rising endometrial cancer incidence, changing population landscape, and these known disparities, we started to ask some questions, which led to this study. So our objective is to examine the ethnic, racial, and geographic diversity of endometrial cancer in BC and to assess if there were differences in management and outcomes. We collected clinical pathology data, ethnicity data, molecular subtype, post-cold, and outcome, and here are our results. So between 2003 to 2016, there was 779 geographical data, 687 of those had racial ethnic data, and 632 patients had molecular subtype data. An overview of our baseline demographics, we had 62% were white European descent, and 38% were visible minorities, similar to what's described in the census. And some things to note is that the age of diagnosis among visible minorities, as well as age of surgery and BMI, were much lower. The non-white group had higher rates of clear cell carcinoma, but there was no difference in LVSI stage, myometrial invasion, or limb syndrome status and adjuvant treatment between non-white and the white population. We further broke down the population groups by ethnicity, and we can see that the proportion of each ethnic group in the total cohort of endometrial cancer is similar to the BC census, with the exception of two groups. The Southeast Asian group had a higher than expected proportion of patients with endometrial cancer compared to the census, and the Indigenous group had a lower than expected proportion. Next, we assessed the overall distribution of the 4 promised molecular subtypes, and it was predominantly similar to the rates found in literature, although we note that the P53A rate is a little bit higher at 21%, where it's normally typically quoted around 15 to 18%. Otherwise, all of the other distributions were quite similar and inconsistent. We looked at the promised distribution between the white group versus the non-white group, and there was no significant difference in the subtype difference. They had very similar distributions, as you can see. However, we know that the visible minorities make up for a third of the population, so we further broke this down into a molecular subtype within each ethnicity. These are the top 4 majorities, so the white population and Asian populations. They had similar subtype distributions. However, some important differences to note was that the East Asian group had a high proportion of NSMP and a low proportion of MMRD. And the Southeast Asian group had a high proportion of P53, which is the most unfavorable type of subtype, at 24%. We also looked at the 4 ethnic groups that made up the minority of the distribution, and their distributions of the subtype look very different from the row above. Especially the Indigenous group had a high proportion of MMRD. Middle Eastern group had a high proportion of POLI, which is a very favorable subtype, and there was only 1 Black patient who was P53 positive or abnormal. In terms of management between the racial groups, there's no difference in the time from diagnosis to surgery, rate of nodal testing, or adjuvant treatment. No difference in the overall survival analysis when we compared the white, the Asian ethnic groups, and all of the other ethnic groups. In patients with MMRD and P53, there was a trend towards worse outcomes for visible minorities. And just quickly going over geography, most patients were diagnosed in an urban center within 1 hour driving distance to hospital. No difference in the promised distribution. I know you're coming, I see you. No difference from time to diagnosis and the stage of diagnosis based on geographical parameters. And no difference in the treatment and outcome. So all this to say is that there's really no difference in the type of cancers at presentation at the management level and the treatment level in terms of geography in BC. Really quickly to summarize, so we do see some molecular subtype differences within ethnic groups, but this data is not up to date and our population is still currently changing. And in terms of future directions, again, to reiterate, the incidence rate is increasing. Our population is diversifying. I think it's imperative we continue to collect this data and to understand this very understudied area of cancer outcomes and to continue to evaluate the molecular classification as it may direct treatment differently on different populations, kind of for a more personalized and targeted care, because this is an unknown area. These are my references, and thank you so much for listening.